Thank you for the introduction, and again, good morning, everybody. I'm excited to speak here today on that topic of cardiac evaluation for liver transplantation in the modern era. As Mike mentioned, the topic continues to be controversial, and I do have to mention that I don't have all the answers for you today, but I'm pretty sure that I will raise some more questions here. I have nothing to disclose. I will start with the background and incidence of cardiovascular disease and continue with the currently available guidelines and finish with the testing modalities that we currently have available. So a liver transplant puts enormous stress on the cardiovascular system, and cardiac risk assessment is becoming increasingly challenging, and that is for several reasons. The mean age of the patient is increasing, and this older population by itself, is the older age is a well-established risk factor for underlying cardiac disease. NASH is now becoming the leading indication for liver transplantation listing, and in some centers it already is. It is, again, also by itself an independent risk factor for cardiac events, and both before and after liver transplantation. And we also see a higher proportion of vascular comorbidities in this patient population. The lifelong immunosuppression contributes to metabolic stress, and it significantly increases the chances for adverse cardiac events. And lastly, we have a wide variety of screening protocols, risk assessment, and subsequent management strategies, especially of the asymptomatic patient. So cardiac risk can be categorized into 3 time periods relative to the liver transplant. So the immediate, the perioperative, the early, and the late post-transplant. Traditionally, our risk assessment is focused on the perioperative and early post-operative period, which impacts mostly the short-term post-transplant survival. During the transplant, we see significant changes in preload, decreases in cardiac output, electrolyte derangements, post-reperfusion syndrome, cardiac arrest, and ventricular arrhythmias. The first 90 days after the transplant, they can be complicated by arrhythmias, heart failure, dilated cardiomyopathy, and MI. So it is important to recognize that that most published guidelines for cardiovascular risk prediction, as we will see later on, they focus primarily on risk for coronary artery disease. However, the studies demonstrate that the risk for coronary artery disease is more of a late complication. Most of them actually more than 1 year post liver transplantation. And they're related to ongoing exposure to the traditional cardiovascular risk factors that may develop or worsen in the setting of a chronic immunosuppression. We know at this point that the overall prevalence of cardiovascular mortality after liver transplantation has been increasing over the years. Cardiovascular events are the leading causes of mortality in liver transplant recipients within 1 year of transplantation. And liver transplant recipients are at a 64% increased risk of cardiovascular events when compared to the general population. And also the hospitalizations for these events have increased by about 115% over the past decade. And just to put it into perspective, the cardiovascular mortality rate for liver transplantation is currently 1.2%, compared to CABG with 1.7% and a cholecystectomy with 0.2%. Let's look at some of the recent data on early and late mortality. Overall, the improvements in surgical techniques, immunosuppression strategies, and management of infections have greatly reduced graft failure. and infections as causes of early mortality after liver transplantations, which used to be the leading causes for early mortality. On the left here, you see data from a recent study by Koshi and colleagues on the causes of mortality in the first 30 days after liver transplantations. They have been looking at all liver transplants in Australia and New Zealand since 1984, over 4,000 total in 7 centers. On the right, we see data from the OPTN database from 2002 to 2012. Here, Lisa Van Wagner and her colleagues showed that among more than 54,000 adult liver transplant recipients, there were more than 1,500 deaths, about 2.9% within 30 days. And cardiovascular disease was the leading cause with 40.2%. So in both studies, cardiovascular events were the #1 cause for early mortality, followed by sepsis and infection. When it comes to late mortality, cardiovascular mortality ranks 3rd. Again, Koshi's data shown here on the left, and a single center study from Oxford Medical Center on the right on patients surviving the first year after liver transplantation. So this pie chart shows the distribution of early major adverse cardiovascular events after liver transplant. This study was done in over 32,000 liver transplant recipients. About 4,400 were admitted within 30 days, and about 6,000 were admitted within 90 days of liver transplant. So MACE occurred in 8% and 11% of the patients at 30 and 90 days, respectively. The most common cause of an early MACE within 90 days were non-ischemic in origin and include atrial fibrillation, heart failure, which makes up for nearly 70% of all cardiac events within 90 days. It was not surprising that they also found that the presence of a 30 and 90-day MACE was associated with a lower long-term recipient survival. A more recent study looked at the evolution of cardiovascular event types over time in liver transplant recipients. The authors here showed that there has been a significant change in the first decade of the 21st century in the types of cardiovascular events that prompt inpatient admission in the post-liver transplant population. There has been a significant increase in the admission for congestive heart failure and dysrhythmias. There's also been a significant reduction in the number of MI admissions, as well as significantly lower admissions for stroke, cardiac arrest, and malignant hypertension. Explanation for the development over time was not provided by the authors, and they also didn't show a timeline from transplant to hospital admission at the time. So who's at risk for cardiovascular complications and to what degree? Here's a list of established risk factors of cardiovascular events in the liver transplant population. The list is divided into non-modifiable, modifiable, and transplant-related risk factors. So what do we do with this knowledge now? There are several risk assessment scoring tools available to predict the development of cardiac disease in the general population. However, these have not been evaluated in patients with cirrhosis. Also, none of the surgical risk scores included patients undergoing liver transplant surgery, and most tools were developed to detect ischemic heart disease, which accounts for less than 10% of early complications after liver transplantation. In 2018, a prognostic model was developed to predict the global one-year risk of death and hospitalization from major cardiac and vascular event after liver transplant. It is calculated based on several pre-transplant characteristics shown here, such as age, sex, race, employment status, highest education achieved, history of AFib, current respiratory failure on a ventilator, history of pulmonary hypertension, history of HCC, history of hypertension, diabetes, and history of heart failure. So as you see, it's a combination of conventional and not so conventional factors. The first table here shows the 1 year absolute predicted risk for cardiovascular events according to that calculated CAR-OLT score. The second figure shows the distribution of CAR-OLT scores among liver transplant recipients and their relation to probability of 1 year post-transplant cardiovascular events. So showing that most patients in the cohort fell within the 25 to 35 category, which puts them at a 20 to 35% risk of cardiovascular complications. The third figure is a calibration of the prediction model with a decile of risk, showing the observed and expected probability matching the cardiovascular event within 1 year. However, the CAR-OLT score still requires some external validation, and it does not address the long-term cardiac risk of the liver transplant recipient. So let's look at systolic heart failure after liver transplantation. As we all know, most patients presenting for evaluation have a normal or hypodynamic left ventricular function, and most transplant centers will decline patients with an EF of less than 45%. We don't fully understand the etiology of systolic heart failure in end-stage liver disease yet, but because most of the studies are case series or small studies, and a lot of them group systolic and diastolic heart failure together. So overall, the incidence of systolic heart failure, depending on definition, ranges from 7 to 27%. In this study out of the Cleveland Clinic, the primary objective was to determine the predictors of systolic heart failure occurring within 6 months after liver transplantation. Of almost 1,300 transplants, 45 cases were identified with stress-induced cardiomyopathy being the most common etiology and accounting for 64% of the patients. So systolic heart failure 6 months after liver transplant was attributed in 10% with acute ischemia as the etiology in 37% of those patients. 1/3 of the patients with systolic heart failure died within 1 year of transplantation. 5 patients with systolic heart failure developed graft failure, and all of them expired within 1 year of transplant. Sepsis and multi-organ system failure were the most common causes of 1 year mortality among patients with systolic heart failure, showing their limited ability to cope with additional cardiovascular stress. Of all the patients with a decline in EF after transplant, about 47% were able to recover their ejection fraction. But the patients who did not recover, they had a significantly higher incidence of NASH and higher incidence of need for pre-op liver transplant dialysis and presence of diastolic dysfunction. In this retrospective study, the authors looked at left ventricular systolic and diastolic function as an assessment tool to predict mortality after liver transplant. So they found that overall a reduced EF and decreased EA ratio were found to be independent predictors of overall late mortality, and also that a combination of left ventricular systolic function and left ventricular diastolic function showed a higher mortality rate than either one of them alone. So guidelines in the non-transplant patient population, they do not recommend screening and revascularization of asymptomatic patients preoperatively. However, these trials might not be applicable to our transplant population, where asymptomatic moderate to severe disease is present in roughly 25% of our patients. The strongest predictors for obstructive coronary artery disease are diabetes, more than 2 AHA risk factors, NASH, and renal dysfunction. However, it's important to mention that if a liver transplant candidate is appropriately revascularized, then the survival is not impacted by the severity or the extent of the coronary artery disease prior to revascularization. Again, this recent study by Alexander and his colleagues in 2019 looked at whether the sum of risk factors proposed by the American Heart Association can identify liver transplant candidates at increased cardiac risk. The primary outcome was the presence of severe coronary artery disease defined as greater than 70% stenosis or greater than 50% left main stenosis on pre-transplantation angiography. They showed that the presence of at least 3 risk factors has both high sensitivity and specificity for detecting moderate and severe coronary artery disease. A little bit more about NASH. It is the most common chronic liver condition in the US, with 20 to 40% prevalence, and is or will become the most common indication for liver transplantation. The cardio, one of the suggested mechanisms is that that hepatic steatosis may lead to pro-inflammatory cytokines, which can accelerate atherosclerosis and lead to progressive endothelial dysfunction. It has been shown that NASH patients are at increased risk for post-transplant cardiovascular events, especially myocardial infarction, when compared to patients transplanted for viral hepatitis or alcohol. So in this interesting study by Patel, it was shown that 1 in 2 candidates with NASH were diagnosed with coronary artery disease on catheterization. 30% of them had obstructive disease, and 10% actually had triple vessel disease. In their study, NASH again was the strongest adjusted independent predictor for significant coronary artery disease. So let's look at the currently available guidelines. Currently, there is no clear consensus regarding the optimal cardiac risk assessment before liver transplantation, and each institution uses its own protocol for risk assessment. Especially the clinical utility for screening asymptomatic liver transplant candidates remains unclear. Our main guidelines come from the American Heart Association, the American Association for the Study of Liver Disease, and the European Association for the Study of Liver Disease. They all agree that liver transplant candidates should have a preoperative echocardiogram, but that's also pretty much where it ends. They already differ when it comes to the indications for pre-op stress testing. AHA recommends more than 3 risk factors. AASLD recommends stress testing in all, and the Europeans recommend for everybody over 50 or multiple risk factors. For performing coronary angiography, the AHA recommends in selected symptomatic patients with abnormal stress test, AASLD in significant coronary artery disease, and as clinically indicated. However, they do not specify any further. The EASL when coronary disease is suspected. As you see, there's lots of room for interpretation here. So what methods do we have available? Let's start with stress echocardiography. It is a non-invasive test that does not test for the presence of coronary artery disease per se, but for the presence of wall motion abnormalities in situations of increased oxygen demand. Overall, previous studies in liver transplant candidates undergoing a DSC screening have shown conflicting results with a wide range of especially sensitivities. There is high heterogeneity among studies demonstrating low sensitivity and high specificity. The low sensitivity is attributed to the blunted chronotropy that comes with cirrhotic cardiomyopathy. A significant number of liver transplant candidates are on beta blockers, and they often cannot achieve the target heart rate of about 85%. So uh, the next step is often myocardial perfusion imaging. It is often performed in these patients with inconclusive stress echo results. However, this test is limited by the chronic vasodilatory state associated with end-stage liver disease, resulting in insufficient augmentation of the coronary blood flow. The sensitivity of SPECT has been described somewhere between 35 to 37%. Reversible perfusion defects have a low specificity, however, a high sensitivity for severe coronary artery disease when compared to angiography. Patients with fixed defects or normal MPI generally do not have severe coronary artery disease. So the gold standard for now in detecting coronary artery disease is angiography. Downsides are it's an invasive procedure. There's a risk of nephrotoxicity and bleeding. However, it allows for simultaneous revascularization. We do see significant stenosis requiring intervention in less than 10% of patients. Another downside is that angiography cannot detect microcirculatory disturbances, which often is associated in patients with NASH and diabetes. So Madur and colleagues showed a significant reduction in their 1-year all-cause mortality and in the incidence of post-transplant MI with the increased frequency of catheterization and PCI over time. They looked at a time span from 2000 to 2010 and divided that into 3 different time periods. They also lowered the threshold for PCI for greater than 50% stenosis in major vessels and greater than 70% in at least moderate-sized branch vessels. The same group in a follow-up study evaluated cardiac risk factors of patients who had a negative cath compared with patients who had a positive cath. And they showed that age over 60, male gender, and history of coronary artery disease were the major risk factors. One of the more recently developed modalities for anatomic assessment of coronary artery disease is coronary CTA with calcium scoring. It has shown very high sensitivity and negative predictive values. However, the risk of contrast-induced nephropathy, it remains, even if the risk is lower than compared to invasive angiography. On the con side, CCTA requires a normal body habitus and the ability to lie still and perform breath holding, which might be challenging for some of the very sick patients. Moreover, CCTA has not been tested against invasive angiography yet. Cardiopulmonary exercise testing is a functional assessment that measures maximum aerobic capacity and aerobic threshold. It is currently a well-established screening method, especially in thoracic surgery. More recently, studies have been describing the utility in the liver transplant population in identifying patients who might benefit from prehab or perioperative optimization. Unfortunately, most of our patients do not look like this gentleman in the picture here. And as you can imagine, this test is often limited by patient deconditioning and effort in the very sick patients. However, overall, it takes 8 to 12 minutes. It's performed on a stationary bicycle and treadmill, and heart rate, oxygen saturation, arterial blood pressure, 12 lead EKG, and end-tidal CO2 are monitored continuously. The test is also only offered in some specialized tertiary care centers. I think currently MGH offers it. Prentice and colleagues have shown a shorter ICU stay in patients who have a pre-transplant AT of 11 and the lower mortality risk with an AT of greater than 9. So again, as Michael mentioned before, our current screening protocol at Leahy is very similar to the European guidelines. Every candidate gets an EKG, chest X-ray, and a TTE. The candidates with a cardiac history, risk factors, and candidates without risk factors over 50 get a chemical stress test. If the test is positive, we further evaluate with cardiac catheterization and possible revascularization with either stent or CABG. However, often the decision is still made on a case-by-case basis together with our colleagues from cardiology, hepatology, as well as surgery. So a lot of things that we don't know at this point. The actual impact of cardiac risk assessment protocols and outcomes before and after liver transplant is not really known yet. And so it's very much encouraged that all liver transplant centers actually publish their protocols and their outcomes. As we have seen, there's still the lack of consensus when it comes for clinically meaningful post liver transplant major cardiac event evaluation. And the intervals of repeated risk assessment, we also really don't know what the best way to perform the evaluation at this point is. And that's pretty much all I had. Thank you very much.
Thank you, Florian. Great talk. As I mentioned in the chat, if anyone has questions for any of the speakers, please put your questions in the group chat through Zoom, and I will ask one or two selected questions as time allows. Florian, there's a couple of questions. One is relating to cardiomyopathies, and the question is, if a patient has a history of stress cardiomyopathy resulting in ICU stay or requiring ICU stay, would you consider this patient for a liver transplant?
With a fully recovered stress cardiomyopathy, it's a very good question. I would have that patient undergo our current protocol if the reduction of the ejection fraction, or if the episode is longer than 6 months to 1 year ago, and I can retest him, I would probably consider him.
Another question is about obstructive CAD. How does your group decide on obstructive versus non-obstructive CAD? I guess, what percentage do we use? Do we use FFR, fractional flow reserve? And do you use CCTA at your center?
We use the greater than 70, greater than 50% in the main vessels, and greater than 70% in the moderate vessels. I do not think we do CCTA. Mike, do you know?
I don't think so. No. I will just to follow up. The management of coronary disease in these patients has been a subject of many presentations and many talks at various national meetings. And there was, at one time, the UCLA group has used a very aggressive approach, basically stenting everyone with anything greater than 50% stenosis. And I believe there's still a group in the Midwest, I can't remember if it's Indiana, that still does that, but they haven't been able to show any um, improved survival data. We have time for a few more questions. There's a question about how do you assess patients with end-stage renal disease? Should they all get a cardiac cath?
So in those patients, and I think it's actually it's equally or if not more difficult in the end stage renal disease population, because the incidence of coronary artery disease there is almost 100%, or from what we see in the clinic. And also I think the topic comes or is much more prevalent in how often do you screen them, because they're on the wait list for 5+ years, right? So I think this is a decision that has to be made together with nephrology, because if someone who has, it depends on the remaining kidney function, are you gonna give contrast to those patients or not, or is the kidney function decreased to a point where it's not gonna make a difference? I think in this case it's very important to the multidisciplinary approach of nephrology, cardiology, and anesthesia.
I think I'm just going to follow up. If it's a patient who's going for a dual organ transplant, the liver kidney, and they are on dialysis, um, I would say that in our center, the majority of the time they do get a cardiac cath, just because, as Florian said, the prevalence of coronary artery disease is very high. There are, of course, exceptions. There are patients who sort of have what we would call acute on chronic liver failure, and subsequently develop renal dysfunction and spend more than 4 weeks or more than 6 weeks on dialysis, and become eligible for an SLK. I think in those patients we sort of assess their likelihood of risk factors for having coronary disease, similar to somebody who has just requires a liver transplant, because in those patients the prevalence of coronary disease is probably lower. That's typically sort of a younger patient with either really bad alcoholic or cholestatic liver disease.